Dear colleagues, because we lost a lot of time, I'm really very happy to join now the lecture of Ajay Kirtane from Columbia, from New York, and his topic will be renal denervation approach, current data, and how to perform it for optimal outcomes. Ajay, welcome, and just start with your slides.
Good evening, Ajay. Again, thanks for your time again. In India, as you know, I think you are aware now, the RDN just about to come. As of now, we are supposed to get these catheters on special permissions, but in a month or two, it will be freely available commercially. So a lot of interest again coming back on RDN in our country. That's why we requested you to share your experience. Over to you.
Thank you so much, and it's great to see everybody. Miroslav, good to see you too, Mark. And for all the folks I didn't see yesterday, it's just sad we can't be there in person, but full support to this meeting from myself and all of my colleagues. So I wanted to talk a little bit about, can you hear me?
Maybe next year we will be able.
Oh, that's right, I hope. So I want to talk a little about denervation, and I'm not going to go through the data in detail. I'll just show you some summary data, but then I just want to talk about the principles of the procedure to sort of make it a little bit practical. The main conflicts for me is that I have research grants from Medtronic and Recoil Medical. Just to set the stage, India is not in this slide, but this is in westernized countries, and even though we have many medications out there, we fail to successfully treat hypertension in a great number of patients. And if you think about how significantly hypertension is tied to adverse cardiovascular outcomes, this means thousands of millions of patients with burdens of disease, of heart attacks, strokes, other diseases, kidney disease, that really could be potentially treated. And so we need better ways to treat blood pressure. Now, some of this is education. Some of it is trying to emphasize adherence. I know India has been at the forefront of some of these programs to sort of SMS people and have them be more adherent to their medications. But it's clear that even with medications, patients have side effects. They don't want to take them. And so there may be a role for other therapies to treat blood pressure. Does that mean that that therapy will reduce completely the need for medications? No, you need to still take medications. You still need to do lifestyle modification, but for some patients, it may afford an alternative. Now, this is just a meta-analysis we put together in 2019, looking at what the effect of blood pressure lowering is. And the reason I show this is not to show you that, yes, renal denervation works compared to sham-controlled trials, which is actually true. It does work. But the more important thing is what the magnitude of effect is. And when we look at this, this is a magnitude of effect of ambulatory blood pressure. And these are patients with not severe hypertension, but sort of mild to moderate hypertension of 5 millimeters of mercury total. So what we're talking about is the effectiveness of one medication per se, because if you take somebody with more severe hypertension, it's not going to be 5, it's going to be higher than that, but it's not going to replace medications altogether. And that's why I think what I really want to emphasize to all of you there is that when you have this at your disposal, it's not something that's going to be a panacea, and it's not something that's going to obviate the need for you to look for secondary forms of hypertension, for telling people that they need to lose weight and do all the things that they need to do. Now, more recently, we've seen data in more resistant hypertension in patients on medications. And I was fortunate enough to present one of these trials at the ACC last year and published in the Lancet. And this is Radiance HTN Trio. And if you look at the reductions in some of these trials, so this is on patients who had resistant hypertension, so blood pressures that were quite elevated, despite being on 3 medications at the same time, a calcium channel blocker, a ARB, and a diuretic, the reduction was 8 millimeters of mercury. Now, placebo or sham went down 3, but remember, some of these patients had medications added on and off. And so what we're talking about is a reduction from baseline of 8 millimeters of mercury. And that's a similar effect that was seen in spiral HTN on meds. And so this is the Medtronic study, and I'll show you the differences in catheters. So for patients that have more severe hypertension, now we're seeing greater reductions, not to the point where they can eliminate their medications, but to the point where somebody who's not controlled can then become controlled, and thereby, we hope, reduce their risk of cardiovascular outcomes. So who would be the ideal patients you might be selecting for renal denervation therapies? And I think this is kind of the take home for all of you. I put it earlier in the slide just so it can sort of frame how we're going to do the procedure. So number one, it's going to be hypertension that's either refractory to conventional medical therapy and lifestyle, or with adherence issues. So somebody who just can't take their medications because of side effects, somebody who've tried to take their medicines but can't get control in that way. And I do want to stress, especially in a younger population, because in India, I know you see a large population of younger patients, it's important to rule out secondary causes. So make sure you feel the pulses, make sure there's not a coarct or something else, be a good clinician so that you can rule out reversible causes, hyperthyroidism, things like that as well. It's typically going to be patients with sympathetically mediated hypertension. Now, we don't typically test the sympathetic nervous system, but it's probably patients that have more obesity, elevated BMI. It doesn't appear to be hypertension mediated by arterial stiffness. So if you have a 85-year-old with severely calcified vessels and they're hypertensive, it's going to be less likely to be effective in that patient population. But a younger patient who comes in obese, metabolic syndrome, every time they see you in the office, the blood pressure is much higher. They say at home it's not that high. These might be patients who will be better targets for it. And then finally, it's going to be anatomy suitable for denervation. So this is going to be variable by the device, and I'll explain why in a little bit. And then also, you don't want to have somebody with a stenosis. One final word I'll make with regards to medication selection that we found specifically from Radiance HTN Trio, and something that I've adopted in my clinical practice, is that there are combination pills of medications where everything is combined into one, and they increase adherence to medications as a whole. And in this trial, that was the design of the study. You took patients and they were on multiple medications, and we all put them on a single combination pill. And remarkably, a large proportion of patients who were not controlled on the same doses of the three medications became controlled when all those three doses were combined into a single pill. So my point to this is that that's something that I do in my clinical practice, and that may be a way to treat patients more effectively with medications, and then they may not need a separate procedure, or in some cases, then you demonstrate that they fail, and then they would go for a procedure. So one of the challenges of initial therapy, and this was the initial studies, and because some people say to me, well, you know, you all did a bunch of studies now that to show it worked, but they're not as big as the initial study, and that initial study is what really where the data was. One of the challenges, that's true, that was a larger study, but one of the challenges with the Simplicity Hypertension 3 study is that it took a catheter that was basically a unipolar radiofrequency catheter, and we were trying to manipulate it in multiple directions as we were coming out of the renal artery. And what you see here is you get these spot ablations in a quadrant, and you're only going to get renal denervation if the nerve happens to travel in that distribution. And so this was an example of what the procedure looked like. So what's the access? Standard femoral access, because at present the catheters are designed from femoral. You basically take a diagnostic catheter up as needed to be able to see what the angiogram looks like. If the angiogram shows that there's no stenosis and the vessel is fine, then you would use a guide. You can use a diagnostic telescope through a guide as well. And then this catheter did not have a wire associated with it, and you sort of basically had introduced it into the vessel, and then we're sort of turning it back and around in various quadrants to try to achieve what you thought was an ablation, and you couldn't actually measure it at that time. Now, there are cases with renal denervation where you're going to see iliacs like this. So in this case, this was a stiff wire I put up on this side, had a sheath on this side to sort of straighten things out to be able to deliver my catheter in an effective way. And this is how we did it. So some of these cases do require a little bit of more advanced techniques, telescoping guides. You have to be careful not to dissect the renal ostium, because the last thing you want to do is to put a stent in these cases. But by and large, these cases were able to be done, although the challenge with this catheter was that this was a 2-minute ablation and the patients were breathing. So the screen was going up and down and up and down, and you were perhaps even losing contact. So this was clearly not good enough, but this was the device that was studied in the initial study that was negative. And that's one of the reasons why the device has been iterated over time. The other reason it's been iterated is because what happened initially is that we thought, and we were taught, that all the renal ganglia was here at the ostium, and so it was most important to just hit the ostium, and you didn't really have to go more distal. But it turns out that that was actually wrong, and with more anatomic studies, you can appreciate that, yes, there are ganglia near the ostium, but the distance between the vessel here and the nerve is much greater here than it is further distally. And so you have to be able to overcome this issue by one of a variety of approaches. One approach is to go more distally, and that's what Medtronic has done with the Simplicity spiral catheter. And what other companies have done is they said, okay, well, we're going to ablate more proximally, but we're going to do it in a circumferential pattern so that we can get all the nerves in the vicinity, and we may do it a little bit deeper than you need to do with a radiofrequency catheter. So this is just an example of what happens. Here's the renal artery here. If you do a radiofrequency ablation over here, anything in this zone will be ablated, but anything beyond that zone will not be ablated, because with radiofrequency, you don't want to go too deep, because that can cause a wedge-shaped ablation pattern that goes deeper and gets into visceral organs and other things like that. The other thing to notice is that with this catheter, it's an asymmetric zone of treatment. It's not circumferential, because if you did a circumferential radiofrequency ablation, you would perhaps compromise the lumen, because you would cause a restenosis. So with that in mind, knowing that it's asymmetric, the question is how many ablations do you have to do in order to get the blood pressure to go down? And there was additional data that came out after and during the time of the Simplicity Hypertension 3 trial, showing that you actually have to get a significant number of nerves affected. Basically, more than 50% of the nerves have to be affected in order for your norepinephrine levels to start coming down. And that's one of the other reasons that this initial catheter that was a single polar catheter, just 4 ablations on the side, was not going to be enough in order to achieve successful denervation. And to Medtronic's credit, they've done further studies showing that if you treat just the main branch alone, you do not get enough denervation to be reliable. But if you do the main branches, main vessel and branches, that's where you start getting significant reductions in norepinephrine to achieve a durable effect and a reproducible effect. So this spiral catheter was designed with this in mind. This is what I think you're going to have access to very soon. And the idea of this catheter is to make things a little bit easier for getting the catheter down distally, because the idea is to be able to get as many nerves as you can possibly get. So same sort of principle, you put a guide up in the renal ostium, but this time you can take an 014 wire, you advance it into a branch vessel, you advance this catheter, which will track, and then you pull the wire back. When you pull the wire back, it forms a spiral. It's pretty flexible, so it's not going to be stiff in that vessel. And with that spiral, you get 4 ablation points, and you don't have to sort of, worry about the patient breathing and moving up and down, because of the spiral itself, it'll be stable in the patient's vessel. So you do these ablations, and you do as many branches as you can, and then come back and do the main branches. Now, there is a study being done currently looking at whether you need to do the branches plus this main vessel, because if you think about it, if you get the branches of the tree distally, if you prune them distally, you're blocking signaling, and so that may be sufficient. You might not also have to do the main branch, but that's something that it remains to be determined. And this is 6 French guide catheter compatible. We do anticipate there will be radial devices that come out soon, but at present, my understanding is that this is just going to be femoral. Now, there are other approaches as well. And so this is the Recoil System, which is an ultrasound-based system. It basically employs a system where you heat with ultrasound at a depth of 1 millimeter to 6 millimeters, but there's a cooling balloon for the lumen so that you don't cause a stenosis by going circumferentially. And so this is a different principle. Instead of doing these focal wedge-shaped ablations and multiple ones distally, the idea here is to go centrally and to do an ablation in this way. So circumferential, you get everything from 1 to 6, and you spare the lumen in that way. So this is just an example with thermal gel of what happens. This is the catheter being turned on. Here's the cooling balloon here. And as this starts activating, the zone of ablation is here. And you can see the lumen here is spared, so that you don't typically get a stenosis with this type of technology. This is also a shorter ablation time, about 7 seconds as a whole. So here's just an example of a procedural angiogram. Once again, guide catheter here. This is a wire down distally. The balloon is then advanced into the vessel. The balloon is then advanced into the vessel. It's pretty straightforward. You stop flow, you take an injection, there's no more flow. You press the button, you get your ablation, and typically you do 2 to 3 each side, and then you're done. One thing to think about is that, remember, number one, you want to be very meticulous, not causing any dissections, not causing any guide trauma to the ostium. And the second thing is that in some of the earlier cases, You would see spasm, specifically with the Simplicity Flex catheter. It's rarely seen with this catheter. It's not so often seen with spiral, but if you need to give nitroglycerin or something like that, you can give that at the end of the case. Another way of doing it circumferentially is with perivascular denervation using needles and ethanol ablation. And so this is the example of this catheter where there's sort of 3 needles, ethanol is injected, you get a circumferential ablation, once again, a little bit deeper. Now, just a few final comments that I'll make is that number one, there does appear to be individual variability in patients who are treated with renal denervation. There are sure patients who get marked reductions in blood pressure. There's patients who have no effects, and there's some patients whose blood pressure actually goes up. Now, one of the problems is I think for those of us that are in the hypertension space, if you realize blood pressure is very variable and it varies from not only measurement to measurement. If any of you have hypertension, if you measure your own blood pressure, you'll note that if you measure it 3 times in a row, those 3 numbers can be very different just over a 5-minute period. Similarly, it will change based upon what medications patients are on. So if there's institution of medications, I would perhaps bet that this reduction of 50 millimeters of mercury was not just denervation alone. This was a patient who likely wasn't taking medications here, got denervation, and may have taken some medications here. So you're seeing the effectiveness of denervation plus medicines compared to no medicines at baseline. And so that's why it's important to put all these things in perspective and think about more population means when you treat it. But the problem is it also shows that it's variable. And so if you're a patient, you're coming in for a procedure and your blood pressure goes up, I don't think you're going to be very happy with the physician who treated you. And I think in India, this is very important to set the expectations right for your patients, because otherwise there are going to be patients who come in and are not going to be happy. So what are ways that you can prevent this? And this is data we presented at TCT 2018, where we showed with the Recoil device specifically, if you left behind accessory renal arteries and did not ablate in them, your effect of the ablation was half the effect if you could successfully ablate the main branches on both sides where there wasn't an accessory. So bottom line is you need to identify the accessory arteries, and as many as can be treated ought to be treated. One of the advantages of the spiral catheter is that it can fit into smaller branches. So with a single catheter, you can get the branches of the main vessel as well as the accessory arteries in addition. And I think in general, it's going to be a more complete denervation that's associated most reliably with a drop in blood pressure. There are other patients who won't respond. I've mentioned before arterial stiffness. This is a paper looking at how stiff patients' arteries were and what the proportion non-responders were. And basically the highest quartile of stiffness, this is typically going to be elderly patients, were ones who had a greatest rate of non-responsiveness. There are going to be some differences based upon the catheter itself. These are just thermal gels showing 2 different catheters and different ablation patterns based upon what it looks like. So it's important to know the differences between devices. There have been head-to-head studies on this in radiosound HTN. What was shown is that radiofrequency ablation with spiral catheter was far more effective if you did the main artery plus the branches than the mains alone, and that was not the same effect as seen with the Recoil ultrasound-based technique. But whether this is borne out in clinical practice, especially now with refined technique, remains to be seen. Of note, the rate of responsiveness, though, was very similar, irrespective of what device was used. So some of this may be driven by these large drops, and so when you look at the means, it may appear to favor the ultrasound-based system, but when you actually look at these response curves, some of the mean may be driven by these massive drops, which may be medications in addition, and it's the overall responsiveness rate, which is very similar for all of these technologies. There are some work being done in ways of mapping. Looks like an EP procedure, mapping which areas ought to be ablated. This is all experimental at this time. It depends. It remains to be seen how this is going to fit into clinical practice, but I do want to show it out there at present. It's not going to be something that's been used at baseline. The final thing I'll just end with, though, is that it's not just the efficacy that's important, but safety is really important. Because remember, you're taking patients that do have elevated blood pressure, but you're doing a procedure on them. And if you take somebody who could otherwise perhaps be controlled with medication, and you do a procedure and cause a complication either early or late, that's going to be really bad for the patient in terms of their long-term cardiovascular risk. So what types of complications can you see? I mentioned dissections, I mentioned traumatizing the ostium. There's an initial case series that looks at OCT, small evidence of thrombus seen here during these procedures. We don't typically anticoagulate, we don't typically use DAPT. There's no real clinical sequelae of this, but obviously meticulous technique, heparinization, et cetera, is going to be important. In the early days, with some aggressive ablations, you could actually see stenosis. And this is a case report in the Lancet that had to require balloon angioplasty and stenting to treat. Luckily, this is a very low frequency event. I think some of the changes in technique, not so much focusing on the ostium, have probably helped this, but it's something that you have to be vigilant about. And in all the studies, patients are getting Dopplex ultrasonography or CT or MRI at follow-up to be sure that the rates of safety are low. Even with the Simplicity catheter, this is a large series of patients, the rate of adverse events was really, really quite low. Some of this is hematoma and other things. And in addition, people worry about renal perfusion. It actually does not change over time. And in fact, things like all cardiovascular events in the Global Simplicity Registry, these are a lot of patients. The rate of events is very, very low and basically matches the background of what they would have just based upon their hypertension alone. Similarly, the change in GFR over time, everything is relatively stable. While it drifts down, remember, these are patients that have resistant hypertension, so you'd expect it to drift down that way. The final point to make is that what are the safety data that have been assessed in studies thus far? Well, now there's standardized safety definitions in all the trials. And for acute events, we're talking about events that occur within 30 days. For vascular safety, we're talking about estimation that things would happen if you're going to happen in the next 6 to 12 months. And the longest time point for safety analysis at present is around 1 to 3 years. We're having data now longer from the Global Simplicity Registry and other clinical trials. And we you have to be circumspect. So I think if patients ask you, what's the safety data here? You can say, to date, it looks good, but we still need to follow over time. And if the patient's on the fence, there's nothing wrong with trying medical therapy, lifestyle modification first. And if they fail, then you really don't have options, and then you can have that risk-benefit conversation with them. So with that, I'm going to conclude. Happy to take any questions at this time. Thanks so much.
Yeah, Ajay, thank you for this really fantastic lecture and summary of data we have at the moment. And you showed us also different devices working, and we use this few of them in our center, and we have more and more patients transferred to our center. I think similar way will be also in India and in south part of Asia. Any comments or suggestion from?
So finally, Ajay, you feel that first we should target high-risk patients who are not getting controlled, blood pressure controlled properly with medicines, because anyway they would have high risk, no choice. That would be a safe bet. But I thought safety of procedure is established.
Yeah, it seems very safe at present, but I fully agree. And I know we have live cases waiting, so we'll wrap up. But it's really at present going to be patients with very elevated blood pressure, despite trying with medicines and or complete side effects to medications. That would be my population for now.
Joy Thomas, sir, you see a lot of hypertension, but you're asking question, something you're telling?
Yeah, it was quite revealing about the journey of the renal denervation therapy, what Professor Ajay Kirtane said. And some of the crude methods which I followed with Dr. Narasimhan of Care Hospital. We used to use our conventional radiofrequency catheter. Out of 3 patients I did, 1 patient had a salutary effect, that the resistant hypertension got controlled, but in the other 2, I didn't find any difference. Anyway, there's a long journey to go. It is a wonderful concept, and I should thank Professor for his talk.
Thank you.
Yeah, I think
sir, please.
One quick thing is that the problem with the conventional ablation catheters is that most people were adopting the technique from the original Simplicity Flex study with limited ablation points. And that's why the spiral catheter has been designed specifically to go into these branches. And I think, especially showing that the animal data I showed you, that's going to be the only way you can reduce your norepinephrine enough to have an effect. So my feeling is it's not going to be 3 out of 3, but it may be 2 out of 3.
I think we were at the beginning when the wheel was just being invented.
Thank you, sir. Thank you.